All right, so I want to really, my goal here is just to talk about two things, although it kind of spirals out of control when we start talking about these two things. But the two things I want to talk about, one, Ohm's law. What is Ohm's law? So current has a relationship with voltage and resistance. I think when we talk about in electrical terms, all of that sometimes gets confusing. So I like to think of current as the impact to the patient. If we're looking for a muscle contraction, that's the sign that we have good current is that the muscle is contracting. If we're looking for pain relief, the patient says, hey, it feels nice, right? So, that's what the outcome. So current is the goal that we're looking for. So this is Ohm's law. And I think when I first mentioned Ohm's law, everybody sat back and goes like, oh my God, I don't want to listen to this, right? So, and that's okay. Although we've been messing around with Ohm's law every single day with every single wave of stim, we've talked about how to play with this all of the time. So first off, can we change the voltage? Yeah, how do we do that? Yeah, spin the dial. You don't feel it? Great, I'll turn it up higher, right? So we can change that. Although there's sometimes we've figured out like, geez, I keep turning this up. I think you're have this where it's not really feeling it. I keep turning it up, right? What do we then do? What is the troubleshooting? Well, we troubleshoot, is the machine on? Are we plugged in? Do we have the right channel, right? All of that stuff. Once all of that stuff's correct, what are the other things we do? Minimize the resistance. Absolutely. In what ways do we do that? So we could heat tissue, increase contact of the electrodes. What else? Clean skin. Remove hair. What else? Pad location. What are some areas we know have decreased resistance?
Less water.
Ooh, I think that's the opposite answer.
Specifically, or areas within.
More water is less water.
More water is less resistance. So if there's an area of adipose tissue compared to other tissue like muscle has lower water content to it. So an area of adipose tissue is going to have more resistance to it. So especially when we have things like IFC, where we've got multiple pads, big area, there can be a difference in adipose tissue between the pads on that kind of big area. What are some other areas that we know if we change the pad location, they have lower resistance? There's three off the top of my head. Motor points, trigger points, acupuncture points, acupressure points, acupuncture points. So those are the three that I would think of. What is a trigger point, by the way? Exact location of pain. Good. And what does the patient describe when we, what does the clinician feel when we palpate a trigger point? Similar to an area of increased tissue density, tightness. I mean, it is obvious like, hey, that's tissue is dense there. What does the patient subjectively talk about? Really, the radiating pain is the hallmark of the trigger point. They say it feels like a firework exploded. As soon as we touch it, boom, that pain just radiates away. All right, good. Pad location is another one. I've got one other written down. I'm sure there's probably others, but I've got one more written down here on ways we change resistance. Oh, that's a good one. I didn't think about that. Hydration of patient. Hey, before you come in, if Kiki's our patient and he's got high resistance just naturally, we say, Kiki, on your way in, I need you to drink this jug of water. That's going to help us. Good. One other thing I can think of. Boom, there we go. Pad size, bigger the better, right? The biggest pad that's available to us that fits in the anatomy we're trying to work for. That's always the goal. So isn't it funny when we talked about Ohm's law and we tried to learn it, and it was one of those things you guys nodded your head when you're first here and then quickly just said, I don't want to ever think about that again. But we've been messing with Ohm's law every single day that we've been talking about electrical currents. It doesn't matter what electrical current we were talking about. We've been playing with Ohm's law. To get the best current, one, we turn up the machine. Two, we change the amount of resistance with that tissue. Does that make sense now? Does Ohm law make sense now? All right. So again, I mean, it's just one topic, but man, how did it spiral? Not only do we cover Ohm's law, but man, we've also troubleshot all of the different things, and hopefully we understand the different mechanisms on why all of these things can decrease resistance, because it's really important. All right, is anybody who's got Dan's and Isabella's number? So, oh yeah, can somebody snap a picture of this just to make sure that they get it? I am recording this, but I'm not sure they'll be able to see it well. So can somebody either just take a picture and send it to them for me? All right, we good? Everybody else good? Anybody else need to write more down? All right. All right, so Mary inspired me the other day with what she was trying to do. So I sat at work, and instead of returning phone calls to therapists and docs, I just started working on this class. So, all right. So we have, the way I broke down our eSIMs, we have three kind of topics of the eSIMs, kind of reasons, fundamental reasons we would use eSIM. What were those three reasons? Pain. All right, so you're giving me some sub reasons. Pain is one of them. Muscle strengthening is another. And then tissue repair was the other category. And in tissue repair, I would put edema. There's some other things there, but so let's start with pain. What pain forms of eSIM did we use? TENS, perfect. So let's stay with TENS for a minute. We have two different versions, either sensory or opioid. Okay. What's another? IFC, perfect. And then what's the last version that we did? Pre-mod, good. All right. Why would we choose TENS over the other two versions? We'll talk about sensory versus opiate in a minute, but why? What's the big benefit of TENS? Portable. And sensory versus opiate. Why would we choose one versus another? Comfort, more chronic. And why would we choose sensory over opiate liberation? Acute, more comfortable. I think the other thing is immediate relief. Like, oh, you're going to go to your kid's soccer game, walking across the parking lot, up and down the bleachers. You need pain now. Like, it's right now.
That difference between sensory and opiate, like what that. Maybe some different settings, right?
The settings are different. Yep. The parameters are different. What we're trying to do for the opiate liberation is we're trying to get the body to stimulate and release the endogenous opiates. And that will have a longer duration of pain relief than if the battery runs out through halftime of the soccer game, we're walking back with no pain relief. If we put this on before we go to the soccer game for an hour, after 20 to 60 minutes, the pain relief will start kicking on. It'll last for a handful of hours after that. It's just the mechanisms that it's trying to stimulate. This is only working at the gate theory level. We're only stimulating alpha beta neurons, A beta neurons, I'm sorry. This one, we're stimulating the endogenous opiate release chemical. So just slightly different physiologic effects. What's that?
Now, traction, attendance, sensors,
Hopefully, if we're on a motor point, it can, but we can educate our patients whether we want that or not. Yeah. All right. IFC. Why would we choose IFC? Big area. What else is the big benefit of IFC? It's the most comfortable form of E-stim. That's because the carrier frequencies on the most comfortable setting are 4,000. The motor settings closer to 2,500. The difference between the two channels give us the beat frequency. That'll give us the physiologic effect of either pain relief, edema reduction, or muscle stimulation, depending on what we need. But yeah, most comfortable form. Good. How about pre-mod? What would make us choose pre-mod? Annie, I think you had some good ideas earlier.
Basically, if had a smaller treatment area.
Good. Any other reasons?
No.
Not enough stim machines. Someone's already using it. One channel available. IFC, we need how many channels? 2. We got to have 2 channels for it. What's it called when we have 4 pads versus 2 pads? What are those terms called? Quadrupolar versus bipolar. Good. All right. All right, let's go through strengthening next. I'll say muscle. I'm going to use strengthening. Although that term might not be perfect. All right, so we've got 2 different forms for muscle strengthening. What were they? Either Russian or VMS biphasic are our 2 options. Why would we choose Russian or biphasic? What's the benefit of Russian? Bigger area? VMS biphasic? Smaller area? Good. I think more tolerable is probably the better term for it versus comfortable, although I say it's more comfortable. Is VMS biphasic? Anybody ever like, oh, this is comfortable? Like, no, it's just not as bad as Russian. So I think more comfortable is probably the most appropriate term. More tolerable, sorry, more tolerable is the most appropriate term. Comfortable is a little. Now, both of these we could use for different settings. I don't want to get too much into settings, but I want to make sure we understand. I can use, actually, let me write it this way. Just to be sure. Mary, you said there were two different parameters that we could use for this. What were they? What were they for?
Oh,
Perfect. So both of them can be used for both facilitation and both can be used for both strengthening. I think when we first learned this stuff, I think a lot of people thought Russian only strengthening, biphasic only facilitation. It's not. It's both are good for both. It's just really smaller muscles and it's a little bit more tolerable. My last category was tissue repair. We covered three different three different e-stims for our tissue repair. Good. I always call it high volt galvanic. Why do I always call it high volt galvanic? Because galvanotaxy is the mechanism why it works. Good. But our textbook, it's HVMPC, is that the abbreviation? Yeah, but Michelle's nodding like, yeah, no, that's definitely it. Don't worry, I got it. I got my textbook open. It's right here. It's highlighted. There's two different reasons why we could choose, two different parameters, I should say. Okay, I want to talk about that. We had a conversation, we had a conversation about that earlier. I want to talk about that after we do this part. Remind me, you guys remind me because we had that conversation too. All right, but Mary had already said it, edema was one of the reasons why we use high volt galvanic. What are the other reasons? Wound. And with wound, we have two different techniques for it, direct or peri. Peri technique, the electrodes are where? Around the wound, direct. One pad is directly in the wound, the other pad is where? A little bit further away, yeah. But there's still two pads, still bipolar setup. What's another tissue repair e-stim that we had talked about? Why do we choose Ionto? Medication delivery, good. Ionto, keyword medication delivery. If we're going to talk about safety, what are the, like, there's two major things with safety of Ionto that we want to make sure we understand. Oh, all right, so three things. Allergies to medications. Good. What's the other two? Thin skin. And why is that such a problem? Has to do with the type of current. It's a direct current. And that's going to make us nervous because there's a potential buildup of ion, especially under thin skin. So the layer of the safety net that we add to our cells is what? Exactly. How frequently, Michaela? Perfect. One last eSIM that we talked about twice now. Today, I forgot we had to do it, but now we did it. Combo ultrasound. And what's the indication? What's the primary indication for combo ultrasound? Muscle spasm. Good. If we wanted to, we could add another branch down this way and we could list out all of our parameters, all of our every single parameter that we want to. I don't think we need to spend too much time on that. That's something you can definitely do in your studies though for Tuesday. Does this make sense to everybody? Because if you can, it was Mary's idea. So if you understand this, man, can I write, aside from parameters, you know, this is the parameter, what eSIM are they likely using? If I write any question on an exam and say, oh, which eSIM? I think with just a few keywords, you can make sure that, yeah, no, that's the eSIM he's talking about. If I write something like portable, needs to walk around, you know, away from the clinic, what is the eSIM I'm talking about? TENS. And then with the rest of the question, we'll just have to decide whether it's sensory or opiate, or maybe that's not part of the question. I just need you to pick TENS. If I say something like muscle strengthening, or actually, let me exchange it. What if I said something like tells the patient they're only going to use it, it's uncomfortable, but they're only going to use it for 1 to 2 visits? It's going to be Russian for, well, it could be Russian or biphasic for what though? Facilitation. So it's going to be one of these two. So if I give you any of these 6, you know, those aren't those the answers. It'll be one of those two. If I say medication, yeah, that's it. That's it. So I think by going through this, if you just make sure you understand this thought process, I think with just a few keywords in any question, you're going to select the right form. Oh, hold on, Michaela, I think I had a question first.
Oh, so the facilitation is a short treatment.
The treatment time is what was it between 10 and 30 minutes, I think it was. But facilitation, we should start seeing voluntary muscle contraction within 1 to 2 visits. The strengthening protocol is a 6-week protocol. Yep, for either, all it is the size of the muscle. Did you have something else, Michelle?
Yeah, so.
Yeah, I guess we could put it under pain, especially when we did pre-mod, but there are other forms of sim we could use it. So I think it's more versatile than just pain. That's why I chose not to put it in pain. It also, if we believe in the effects of ultrasound when we're delivering the ultrasound waves and affecting the tissue with the ultrasound waves, I think that makes more sense for tissue repair. Ultrasound, the only way that ultrasound helps with pain is just the contact of the ultrasound head, but the effects of the tissue is more of healing. That's why I consider it there. But yeah, it could be both. You're right. There's overlap. You wanted to ask, and we had a good conversation about, well, but in the notes, IFC, we could use it for pain, you could use it for edema, you could use it for muscle contraction as well. That's true. And again, my goal is not to learn everything about every single form of modality that we have available to us. My goal is to teach you the basics and then let you guys figure out how much modalities you want to use. And if there's something new that comes along the way, you got to learn that. So that is true. IFC, we've got a couple different ways we could use IFC. If I'm looking at my patient and my other techniques to stimulate muscle contraction aren't working, there's vibration techniques. I showed that to you the other day. There's tapping techniques that we could do to try to increase that proprioception to get that muscle contract. If those aren't working, all right, I'm so sorry, we got to do this. What do you guys think when you guys were playing with IFC and you hit that motor point? What were those contractions like? Did anybody hit a motor point? It was, what? Say that again, Rob. A little uncomfortable. Compare it to Russian or by VMS biphasic. Quieter, wider. Yeah, I mean, because we got 4 pads to work with, so I think it's a lot harder to get the appropriate contraction with IFC just because we have 2 channels, 4 pads. I mean, that's tough. Quadpolar setup. I think that's difficult. With my Russian and VMS, I know I'm on the muscle because of that reason. I also think when we do these kind of contractions, compare the contractions of Russian and VMS versus IFC. I think the Russian and VMS, it is solid. It is on. It is contracting. It is like there. IFC, almost not as severe. That's how I think of it. If I try Russian with my patient and they say, well, I can't do it, I can't get them to a point where they have a strong contraction with that form of stim, I might say, all right, well, we'll try E-stim because it's more comfortable. It is more comfortable. Maybe I get enough of a stimulation. But man, if I need a muscle contraction, my first choice is here. If I need edema reduction, my first choice is high volt galvanic because I know I can put I know edema is negatively charged, and I know I can put the negative electrode over it. I know negative electrode is going to drive away negative edema. I know that because I played with magnets before. IFC, I know we've got some settings to it. I'm a little skeptical on the outcome. I'll use that if my patient can't tolerate my high volt. But man, with high volt, that's my number 1 choice because I know it's going to affect at the cellular level. That's my personal opinion. I'm a little skeptical on IFC's ability for edema. We can try it, definitely. But I know the negative charge is going to affect the negative edema. That's why I would choose others. Yeah, it's in my back pocket, but it's not my first choice. Does that make sense? If you chose IFC for edema, yeah, you're right. We got settings for it. Yeah, great. Try it out. Our whole career is going to be try something out and see if it works. How do we know if it works or not? Patient response to some degree on some things, especially if it's things like pain. But if we're talking edema, what are some ways we know we measure it? How do we measure edema? Girth measurements or volume meter. Those are the 2 easy ways to do it, right? And man, great experiment would be, hey, you got a big ankle sprain. Let me put this high volt on you. I'm going to take your measurements first, do high volt, take the measurement after. Great. Next time you come in, take your measurements. Now we're going to do IFC for edema and take your measurements again after that and just see which one, was there a big difference one versus another. That would be the perfect study. But yeah, for all of our career, all of the education you get, all of the clinical knowledge you get helps you make a decision You apply that decision to your patient, and then you measure and monitor progress. And if they're progressing, great, you got it right. And if they're not progressing, you got to change something. So that's just where my first thoughts would be for all of these things. It doesn't mean it's the definite, I'm never going to change my mind. It's all patient response, and the patient response, hopefully I can measure. All right, any questions on this? Yeah.
Facilitation.
Yeah.
Even over.
You mixed up Russian and strengthening. Yeah. So for facilitation, yeah, the patient's at a 0. And I've got to jumpstart this muscle somehow. Strengthening protocol, it could be anything, although some of the research says it's not at a certain MMT, it's no better than not doing it. But at the lower MMTs, it shows a faster progress than without for the 6 weeks at least.
The only thing with those two, maybe use like the contraction aspect or that sort of thing. So when the muscles contracting with like Russian or biphasic,
Yep.
you're just telling the patient to do what they can.
Contract with
If
it.
it's strengthening. Something they can.
Well, facilitation, we're going to ask them to try to, because that's going to help that brain-body connection.
Okay.
Facilitation, I'm doing it for the brain-body connection. Somebody had surgery yesterday. They're not all of a sudden a 0 out of 5 MMT scored today. Nothing happened to the muscles. They just had surgery. It's just the injury, the surgery interrupted that brain-body connection, and I'm just jump-starting that.
Okay.
Yeah. All right. Any other questions? So there is a study guide to you for you to use. Go ahead and go through that as well. These are the 2 major topics I wanted to talk about: Ohm's law and then the different types of eSIMs and why we select it. But I said that we'd only cover 2 things, but how many things did we actually cover in those 2 things? A whole bunch, right? So I think the other things that you probably want to make sure of that we've been talking all the time: contraindications. For ion 2, there's some special ones than others. So what is the unique thing? And then parameters is one thing that you guys have been learning all along. So I think you're in a good spot. If you understand the 2 things we covered today and can continue with that study guide, I think you guys are in good shape. Any last questions? All right, perfect.